Okay, I suppose we'll get started. Can everyone hear me and see my screen okay?
Yep.
Cool. All right, so today's talk is on fungi, or fungi, or whatever you want to call them, fungi. The things I thought would be good to cover was both superficial fungal infections, which you're much more likely to see if you're out in GP land, versus the invasive fungal infections, which are not that common, but you probably need to have some awareness that they exist, particularly if you're working in the hospital setting. So, first of all, if you're thinking about how to break down the kingdom of fungi, there's probably two main groups, just to make it nice and simple, and those are yeasts versus molds. So the key differences between yeasts and molds, so yeasts are unicellular versus molds being multicellular. So the yeast basically is one cell, and to reproduce, it buds off a cell from its one cell, so it reproduces asexually by budding. Whereas molds, they're multicellular, they've got these hyphae and spores, so they can reproduce both asexually and sexually. So with the spores, they can just bud off more spores, which is asexual reproduction, but they can also grow by meiosis, making their hyphae longer and longer. So when we're thinking about common pathogens that are yeast, the ones to remember would be Candida and Cryptococcus. Whereas when we're talking about molds, we think of things like Aspergillus. That's probably the most common one. And so picture-wise, so when you're looking at them under a gram stain or something like that, so this is a yeast. You can see there's that, most of the time they're just a unicellular organism, and then sometimes you can see these little buds off the edges of them, which is the reproducing and budding off. Whereas when you've got a mold, you've got these long kind of line up of cells, and you can see the little divisions, these little lines, and those are the individual cells, and then they branch off at different angles. And then you can see these dots, which are the spores, so the hyphae kind of in long tangled lines, and then they go up and have a bunch of spores at the top, or a sporangium. And this is just a different way of looking at it. So these two pictures on the left are molds. They've got the hyphae that branch off, and you can sometimes see these lines, and that's called septate hyphae, and sometimes you don't see the lines, and that's not so important. And then you've got yeasts, and I suppose what this picture is trying to show you is that sometimes yeasts can look like a hyphae structure under the microscope, but they're not all joined. They are just stuck together rather than joined together as part of a multicellular organism, and it's just the budding makes it look like they're stuck together. And then there's one sort of other weird group to be aware of called the dimorphic fungi, and basically they grow both as molds and yeast depending on the environment they're in. And the sort of typical thing to remember is that they're molds in the cold and yeasts in the heat. So that means in the environment they're molds, and when they're in the human body, so at 37 degrees, they're yeasts. So these things aren't that common in New Zealand, but they exist overseas. So America, there's lots of sort of histoplasmosis and coccidiomycosis, and you can see here on the left-hand side, in the environment, they're growing as molds, so they've got the hyphae and the little sticks off with the conidia, and then in the host, so in the human, they're in yeast form. So to go through some of the different fungal infections, I thought we'd just do cases. So we've got a 34-year-old farmer who presents to his GP with an itchy patch of skin over his arm. Started off as a sort of small round itchy spot on the inner arm, grew to a much, much larger circle. You have a look at it, it's sort of dry, scaly, but it's got a quite erythematous look to it. It's got a raised border, and there's some central clearing. And he's otherwise very well. There's no other skin lesions anywhere on his body. So that's what it looks like. Any ideas what anyone thinks this is? First word starts with what it looks like, I suppose.
Ringworm?
Yeah, cool. So this is ringworm, which is an interesting name because it's not a worm at all, it's a fungus. Another word for it is tinea, and it is caused by dermatophytes, which are a type of mold. So dermatophytes, the majority of sort of superficial skin infections are caused by dermatophytes. The most common ones are in the trachophyton group, and those are some other common ones, but don't need to know too much about them. They have a really wide range of clinical presentations, but it mostly depends on the part of the body that they're affecting. So you can get tinea pedis, which is fungal infection between your toes, tinea capitis on your head, corporus on your body, onychomycosis, that's when you get nail infection. And so it's really easily spread between people, but also animals and the environment. The diagnosis is mostly clinical, so just looking at it and saying, I think that looks like a superficial fungal infection, but you can do skin scrapings to have a look at it under the microscope to identify that it looks like a dermatophyte. And the treatment generally depends on whether it's a localized infection or a more widespread superficial infection. So localized, you typically give topical antifungal therapies. So the antifungals which work against dermatophytes would be azoles and terbinafine. If it's widespread, then sometimes you need to give oral antifungal therapy. So again, terbinafine, fluconazole or itraconazole would be the drugs of choice. So I'm just going to show some pictures, and if you could just sort of yell out what part of the body it is, and then we could give it a name. So this one.
Capitis.
Yep, that's a scalp, tinea capitis. This one.
Tinea footis.
Yep, tinea pedis. Feet. This one. Any ideas? General part of the body?
Corpus.
So this is cruris. So that just sort of means the groin genital area. This one someone said before.
Corporis.
Yep, tinea corporis. In this particular area on a male. It's got a kind of weird name, but tinea barbae, which just means it's in the beard, essentially.
So are these all exactly the same pathogen?
Yeah. I mean, any dermatophyte can cause this presentation. Yeah. Cool. So then we've got onychomycosis, and that's just the word just means chronic fungal infection of fingernails or toenails, so any nail. Bugs that cause it, either dermatophytes the most common, and so again, trachophyton of the dermatophytes is the more common one. So that's in about sort of 2/3 to 3/4 would be caused by dermatophyte. But you can get non-dermatophyte molds, so other molds, things like fusarium and things like that, can cause onychomycosis. And then yeasts like Candida can also cause it, but much rarer. And so again, the diagnosis is generally clinical. You look at it and you say, I think that looks like a fungal infection, but you can perform skin scraping, not skin scraping, sorry, I suppose it would be nail cuttings or scrapings, and look at it under the microscope and perform fungal culture, especially if you're sort of not getting the response you expect. Treatment, so for nail infections, they're particularly hard to treat, and that's mostly because the nails grow so slowly that it takes so long for the treatment to be effective. And you generally need to give quite a prolonged duration, like up to 6 months for toenails, maybe up to 3 months for fingernails. If people can't tolerate oral antifungals, but because there are some reasons why people can't tolerate them, might be drug interactions or something like that, and they've only got a mild infection, then it is reasonable to give them topical antifungal therapy. But generally they will need oral antifungal therapy for the nail infections. All right, so case 2, we've got 43-year-old female being treated for breast cancer with chemotherapy. Last week she had a course of amoxicillin clavulanate for a chest infection. She presents to the cancer day ward complaining about having some pain while eating, and she's also noted a loss of taste and a funny sort of sensation in her mouth. You look inside her mouth and you see this. So what do we think this is?
Candida.
Yeah, Candida, oral thrush, any of the above. So we're talking about mucocutaneous candidiasis, so Candida, they're yeasts. They live on skin and mucosal surfaces. So when we're thinking about mucosal surfaces, we mean gut, mouth, vagina. They live there normally. They're just commensals. They're not causing any problems. But infection can occur in the presence of factors that promote overgrowth of the Candida. So those particular factors would be things like immunocompromise, so someone with cancer, diabetes, someone who's on steroids, someone who's got HIV. If you've had recent antibiotics, because that promotes overgrowth of the Candida. If there's foreign material in there, so things like dentures, intrauterine devices, diaphragm use, or if you have increased estrogen for some reason, like the oral contraceptive pill or pregnancy. These are all factors which can promote overgrowth of the Candida, making the Candida cause infection in that area. And again, we've got some body parts. So top left, any ideas what that is?
Mucocutaneous.
Yeah, so it's the mouth, so oropharyngeal. Bottom left.
Vulval or vaginal?
Yep. Oops, somehow we're going across the top. Okay, good reminder for myself. So this is a candidal ballantitis, so involve the foreskin and groin area. So top right. Not a body part you'd be able to look at yourself without a special instrument.
Colon?
It's esophagus, so esophageal candidiasis. Looks like that when you put a scope down. Oh, we're going in a circle. Okay, so this is Candida intertrigo, where you get Candida infection in moist folds. And then the last one is vulvovaginal candidiasis, which you mentioned. Cool. So again, diagnosis you do with culture. Typically it's going to be Candida albicans, although there are other species of Candida which can cause this problem. But especially in New Zealand, we see the majority of people have Candida albicans. Treatment depends on the site. So if you're talking about skin, so intertrigo, so in the folds, you need to minimize the moisture and the friction and the reason why it occurred in the first place, and you can give topical antifungal therapy. So things like azoles, any of the azoles will work against Candida. So things like miconazole powder or cream, that type of thing. Vulvovaginitis, typically you'd give oral fluconazole, just a stat dose. You can give topical antifungals, so either azoles or nystatin, but you need to give them for 3 to 7 days. So a lot of people prefer just the stat oral dose. Oropharyngeal, so can treat that topically, so you can get nystatin drops or miconazole sort of gel that you can put inside the mouth, and you need to treat that for about 7 to 14 days to get rid of it. Esophageal, I suppose esophageal is slightly different to the other 4, because the other 4 would be, you'd expect to get candida in these places in immunocompetent people, but in an immunocompetent person, you wouldn't usually expect them to get esophageal candidiasis. You want to ensure that you can identify the risk factor that means that they have esophageal candidiasis. So, for example, they're on chemotherapy, they had lots of steroids, it would be reasonable for that person to have esophageal candidiasis. But if it didn't quite fit and you weren't really sure why they had it, then you definitely need to check for HIV, because it's kind of one of those sort of classic presentations of HIV. And to treat esophageal candidiasis, you do need to give systemic therapy, so oral fluconazole for a decent dose for a decent length of time, because topical therapy doesn't get down into the esophagus. All right, so we've got case number 3, a 45-year-old male, unwell in ICU, presenting after a perforated gastric ulcer, which he was taken to theatre for a laparotomy and an omental patch repair to cover it up. 5 days later, he's still having fevers, still requiring noradrenaline to maintain his blood pressure above 65 millimeters of mercury. He's intubated, he's got a right central venous line in situ. He's been on meropenem because when they opened him up, he had sort of feculent peritonitis from the perforated ulcer. So even though obviously they washed it out, he's still on broad spectrum antibiotics for that. And he's receiving TPN for nutrition. So you get a call from the microlab saying that his blood culture taken 48 hours ago has flagged positive with a yeast. Does anyone have any idea what diagnosis this guy might have, or what the yeast is going to be? So we talked about yeast before. I'll give you 2 examples. They both started with C. Just take a pick, one of them.
Cryptococcus.
So Cryptococcus was one of the yeasts, but this is probably the other one.
Candida.
Yep. So invasive candidiasis and candidemia. So if you grow candida in a blood culture, you should never consider it a contaminant. It is always a pathogen. The definitions, so candidemia is just the presence of candida species in the blood culture, whereas invasive candidiasis is a deep-seated candida infection. So that when I say deep-seated, I mean an organ that wouldn't normally have candida in it. So like I said before, candida lives on mucosal surfaces and your skin, but it doesn't live, in your spleen or your liver or other bones and things like that. So if you have any of those deep organs involved, then you've got a deep-seated candida infection, and that can be with or without a positive blood culture. So microbiology-wise, Candida albicans is the most common species identified, but there are a range of other different species. So you might hear of them, Candida krusei, Candida parapsilosis, these type of things. It's a gram-positive budding yeast cell when you look at it under the microscope on the gram stain. So gram stain on the right here, so you can see purple, gram-positive, and you can see these round individual cells. Yes, they're grouped together, but they are unicellular organisms. And on a plate, it grows really easily on most media, and they look like cream-coloured colonies. And it's quite classic for them to develop these little sort of feet out the side, which is the budding happening. So risk factors for Candida, risk factors for invasive Candida. That guy in the case had a whole lot of them. And basically what you need is a susceptible host. So immunocompromised hosts, classically people who are neutropenic or have been on a lot of steroids, are at high risk, but also people who have central lines in, and that's because Candida is a sticky bug. It likes to stick to plastic. People who are on nutrition, TPN nutrition, particularly susceptible to Candida because it likes to, I suppose it's just a whole lot of food that it can grow on. People have been on broad spectrum antibiotics because the broad spectrum antibiotics promote the overgrowth of Candida on all the mucosal surfaces and wipe out all the other good bacteria. People who are in ICU, and that's probably because if you're in ICU, you're much more likely to have a central line in, to be on TPN, to have broad spectrum antibiotics or any of these other risk factors, but also just because they're particularly sick. And the other one is if you've had some kind of perforation or leak of your gastrointestinal system, and that's because it lives on the mucosa, like we mentioned before, and most of the time that's not going to cause a problem, but as soon as you get some kind of breach of that mucosa, then that Candida that's living on there normally can then get into the sterile sites that it hasn't been in before and cause infection. So classically you see it in someone who's had some kind of intra-abdominal badness, who's sick in ICU and has got, lines in and is on TPN. That's the classic person that you're going to see candidemia in. That was what I was talking about before. So management, so you want to treat them with an antifungal. So the first line treatment is with an echinocandin, which is another class of antifungal agents, and the one that we use here typically in New Zealand is called caspofungin. And that would be the initial therapy, but it would also be reasonable in New Zealand to treat someone up front with fluconazole. And that's because we predominantly, as I mentioned before, see Candida albicans. But in big centres overseas, everyone would be using a echinocandin, and all the guidelines and evidence suggests that an echinocandin is the thing you're supposed to use up front. But in general, then you can step down to fluconazole once you know the exact species of Candida and what it's susceptible to, and most of the time it's going to be susceptible to fluconazole. And the duration, usually you need to give about 14 days of therapy at the minimum, and the longer duration depends on the source and how well you've controlled it. The next part of sort of management is reviewing for metastatic infection. And when I say metastatic infection, I just mean disseminated infection, more widespread infection from where you originally thought the source might have been. So to do that, obviously you're doing a sort of clinical assessment, but you're also doing surveillance blood cultures. So you're taking blood cultures each day, even if the person's not febrile. And the reason is just to look and see if it's still growing or not. Because if it's still growing or not, that then is a trigger for you to go on and do more investigations. Whereas if it stops growing, you know that you've probably sorted the source and you don't need to worry so much about looking for these other complications. And so if you do have a prolonged candidemia, you want to start looking for abscesses in deep sort of seated spaces. You want to start looking for endocarditis, so it can stick to valves. And another place it does like to go is the back of the eye. So it causes an endophthalmitis, and to find that you need an ophthalmologist to have a look at the back of the eye and see if they can see the characteristic findings of an endophthalmitis. So you don't need to do that in everyone, but you do need to do that if you see someone who's got ongoing growth. But these type of people, they're not common, and infectious diseases teams would generally be seeing these patients if they're in hospital. Source control, so you want to try and identify where the source came from and control it if you can. And so a big part of that is removing the catheter. So when I say catheter, I mean the IV line, whether that's a central line, a PICC line, Hickman line, some kind of indwelling intravascular device. Remove it. Drainage, if there's any sort of abscess or anything like that. And sometimes you need to review the prosthetic material that's in place. So sometimes, for example, people can get infections in their urinary tract, and they might have JJ stents or something like that in their ureters. And so to clear the infection, you do often need to remove that prosthetic material. Otherwise, the candida just colonizes that piece of plastic, and as soon as you stop their antifungal therapy, it can just grow again and get relapse. Right, case number 4.
Question, so can you end up with like a sepsis-like picture from all
Yeah,
that?
definitely. Yep. So people with candida can get very sick and very unwell. So it is, once it's in your blood, it's really aggressive. And so, yeah, people very sick. The problem is it takes quite a long time to grow. So in that case, you might have noticed it took 48 hours before it flagged up on the gram stain, which is really unusual for a bacteria. Like usually you're going to be hearing about that day 1 kind of thing. But often, people can be unwell and they're really unwell, getting more unwell, and you're not really sure what's going on, why they aren't responding to the antibiotics. And it turns out, it's because they were growing a yeast. So yeah, can get very sick. So case 4, we've got a 38-year-old male presenting to ED with headaches and fevers. So he's been feeling unwell for a couple of weeks, increasing frequency of headaches and general fatigue. Over the past few days, the fevers have become more prominent. There's been some vomiting as well. When you sort of examine him, he looks unwell, appears mildly confused. You notice some skin lesions, but nothing sort of focal neurological when you examine him. You have a look at his medical records, and you can see that he's visited the hospital several times with pneumonia, and he's had a recent GP visit where he was diagnosed with shingles, and he's had multiple courses of fluconazole dispensed on his dispensing records for recurrent oral thrush. So, fever, headaches, vomiting. Generally, you're worried about meningitis. So he has a lumbar puncture. Oh, for some reason that came out first. So the first thing he had was a CT head, which didn't show any mass lesions. And then he proceeded to have a lumbar puncture. And he found he had a really high opening pressure of 50 millimeters mercury. The cell count showed a small number of mononuclear cells, so more than is normal, but not heaps. So, between 10 and 100 or so. And he had a mildly elevated protein. So can anyone make a suggestion of a fungal infection you might have, or anything else you think might be going on? So one test comes back and it's a positive CSF cryptococcal antigen, which is a fast test that we can do, which gives us a diagnosis in this case. So this is cryptococcal meningitis. But if we go back and think about his story, about how many times he presented with other infections, does anyone know what I might be getting at?
HIV. Yeah, test for HIV.
Yeah, exactly. So cryptococcal meningitis is a sort of classic presentation of someone with advanced HIV, and the story of sort of recurrent infections, shingles, thrush that doesn't seem to be able to get on top of with topical therapy, all suggestions that this person might have HIV. Okay, so Cryptococcus, it's an encapsulated yeast. The classic sort of stain that everyone talks about is this Indian ink stain, and this is what you can see on the right here, where you can see the capsule lighting up. What if we paused again? Sorry, we'll just wait for the computer to catch up. Okay, finally. Cryptococcus so there's two species. There's Cryptococcus neoformans. So this is the one that's classically associated with HIV and cancer patients and things like that. It's so mostly seen in immunocompromised hosts, and it's found worldwide. It's generally associated with soil that's been contaminated with bird and bat droppings. And then there's this other species called Cryptococcus gattii, which is only endemic in certain regions of the world, so particularly Australia. and it's related to exposure to a particular type of tree. So eucalyptus, it's a river red gum tree particularly. And generally this tends to affect immunocompetent people, and they can present in the same way, so they can get cryptococcal meningitis, but not have the underlying immunocompromise that the neoformans patients have. So typically meningoencephalitis is the most common manifestation, but you can get cryptococcus causing pulmonary lesions. So usually it's a sort of nodule, pulmonary nodules. You can also get cutaneous lesions and sometimes other rarer sites of infection. So like I said before, it's generally seen in immunocompromised hosts. So advanced HIV, typically people with CD4 counts less than 100. Hematological malignancies and solid organ transplantation, again, have enough immunocompromise to be able to get cryptococcal meningitis. It's typically a subacute presentation when you compare it to other types of meningitis, so occurs over a week or a few weeks rather than a very acute presentation. So fever, headache, confusion, can see focal neurological deficits. Sometimes you can see skin lesions, because it is not uncommon for people to have a sort of disseminated infection, and the skin lesions typically look like these sort of skin-coloured, flesh-coloured papules, and classically they've got an umbilicated centre, and the other thing that they look quite similar to is molluscum, if anyone's ever seen that. So diagnosis and management, so the CSF is sort of a key part of the diagnosis. You expect high opening pressures, so this is really classic of cryptococcus to cause these high opening pressures, and the high intracranial pressure is responsible for a lot of their symptoms. They have a low to moderate white cell count with a mononuclear predominance. You can do this CSF cryptococcal antigen, which is a quick test, and it's got a high sensitivity and specificity. You can also do a cryptococcal antigen on serum as well, which should be high in someone who's got sort of cryptococcal meningoencephalitis. So if you aren't able to get an LP, then that's another quick test you can do. And generally, you should be able to grow the cryptococcus on culture, although obviously that takes a bit of time. So management, obviously this management stuff is quite specific and you don't need to know about it, but I'm just letting you know. So the induction treatment is with a medication called liposomal amphotericin B, which is another class of antifungals, and its trade name is Ambisome, and then a second antifungal agent called flucytosine. And the key part of their management is really to manage their intracranial pressure. And so what they often need is repeated CSF drainage. Like some people need daily CSF drainage where you just take off. So you basically put in your LP, you measure your opening pressure with a manometer, and you just take off as much CSF as you need to get there to halve their opening pressure. So that can seem like a ridiculous amount of CSF that you're taking off, but that is what they need. And then after they've had their induction treatment and things are improving, then they can be put on maintenance treatment with fluconazole. So it's a yeast, generally fluconazole is going to work against it. But just when they're sort of really unwell and sick, then they do better if they get the ambisome up front. And then often what you're waiting for really until you can sort of stop being worried that they're going to have relapses or anything like that is a reconstitution of their immune system. And so what I mean by that is the reason why they got it in the first place was because their cellular immune system is not working well. And so if you can improve that, so for example, if they've got HIV, start them on antiretrovirals, get their CD4 count up, and once it's up, then they're not going to be at risk of getting the cryptococcal infection again. Or if they're a transplant patient or something like that, try and reduce their immunosuppression, get them through that period where they're at increased risk of it. So now we've got case number 5. So this is a 25-year-old male with acute myeloid leukemia who's currently undergoing the second cycle of his induction chemotherapy. He's been neutropenic for 14 days and has been having fevers for the last 9 days. He is on meropenem, so he would have been sort of escalated to that because he was having ongoing fevers, but so far there's been no positive microbiology to help direct his antibiotic therapy. And as part of his further workup, for the cause of the fevers, he undergoes a CT of his chest. And this is what you see on his chest, CT. So this is a nodule with some surrounding ground glass change around it. And this is classic for invasive mold infection, and the most common invasive mold infection is invasive aspergillosis, and that's the one we'll talk about here. So aspergillus species are molds that are ubiquitous in the environment. So you can see on the plate, that's what they look like when they grow, and this is what you see on bread. So if you ever leave bread out, grows a mold that looks like that, it's probably aspergillus. How you get it, so basically the conidia, if we look at this picture in the middle here, conidia are all these little dots coming off the sporangium. You inhale them, and then they can progress to an invasive infection with vascular invasion and tissue necrosis. And they are the most common cause of invasive fungal infection in heavily immunocompromised patients. And for the particular people who are at risk, prolonged neutropenia, so people who are on chemotherapy for AML or ALL often will be neutropenic for 24 to 30 days. So that's, once you get much more than sort of 10 days of neutropenia, then you are at risk of these types of infections. The hematopoietic stem cell transplant group, so people who've had a transplant for their leukemia, they'll have a neutropenic period as well, often not as long as the induction chemotherapy for AML, but still a reasonable length of time. Plus, they then get additive risk on top of that because they often need to get steroids for graft versus host disease or something like that. And so that's a risk group. And then other risk groups are lung transplants, particularly of the solid organs. The lungs are the ones that are most likely to get mold infections. How do you diagnose it? How do you treat it? So diagnosis, basically you want a lower respiratory tract specimen. So that's often going to be a bronchial wash specimen. So they'll need to be taken to theatre and have a bronchoscopy and have some of that lower respiratory tract sampled, or a biopsy. So if you can get a CT-guided biopsy of one of those nodules, then that's the best type of sample. And then on that sample, we do culture, but we'll also do histopathology, looking for the hyphae and the tissue invasion. There are some other non-culture diagnostics you can use. So there's this test called galactomannan, which is a fungal cell wall antigen of the aspergillus, and you can pick it up on a blood test, but you can also pick it up on the bronchial washing sample as well. And you can also now do some PCRs directed at aspergillus itself. And the other classic sort of way to diagnose it, well, not way to diagnose it, but it's part of the diagnostic workup, is imaging. So classically on chest imaging, you'll see nodules with surrounding hypoattenuation. So that's just that ground glass kind of patchy change. And you can also see cavitation, and cavitation generally is the progression of disease, like it starts off as a nodule and then cavitates. So management of aspergillus, voriconazole is the antifungal of choice. So that's an azole, but fluconazole generally doesn't work against molds. So you need mold active azoles, and so that's something like voriconazole. Surgical resection might be required, so sometimes you do need to think about whether cutting these infections out is the best thing. And then again, they need reconstitution of their immune system. So in these groups, it's usually, trying to get their counts back up again so they're not neutropenic, trying to get them off the steroids, that type of thing. Last case, so 65-year-old female presents to ED with fever, cough, and breathlessness. She's been on oral antibiotics from her GP for 5 days and progressively become more unwell. Background is that of rheumatoid arthritis, and she is currently on regular methotrexate. And recently she required a course of high-dose steroids to control a flare of arthritis in her hands. So you go to examine her and find that she's got SATs of 88% on room air, respiratory rate of 32 breaths per minute, blood pressure is normal, heart rate's fine, but she's febrile at 38 degrees. Have a listen to her chest, and you can sort of hear bilateral coarse crepitations, but there's no dullness, particularly to percussion. And she has a chest X-ray which looks like this. So can someone describe what they can see on that chest X-ray?
Almost looks like a snowstorm appearance in the parenchyma.
Yeah, so this is bilateral, widespread interstitial infiltrates. So they look very fluffy, but they're not really kind of dense. Like you don't typically with a lobar pneumonia or something like that, you can't really see through it, whereas here you can. Does anyone have any idea what fungal infection can cause this? So this is PJP, Pneumocystis jirovecii pneumonia. It's a yeast-like fungus. It's a bit of a weird bug, really. Previously, people thought it was a protozoa because of the way it looked on the tissue specimens. We can't grow it, but gene sequencing and stuff suggests that it is in the fungal kingdom. It's widespread in the environment. It doesn't cause infection in healthy people, so it's what we call an opportunistic pathogen. So if I swab my nose, I could have it up there, but it's not going to cause infection in me. People who are at risk of infection are people who have advanced HIV. So it's another classic kind of, if you see it in someone who you don't have another risk factor for, then you definitely need to do an HIV test. And actually, to be honest, anybody who is diagnosed with PJP should have a HIV test, even if you know that they've got another reason for getting PJP. So steroids is another major sort of risk factor, particularly people who've been on prolonged course of steroids, so for more than 4 weeks at a decent dose. Stem cell transplants, solid organ transplants, other immune therapies that cause lymphopenia particularly. The classic sort of clinical presentation is characterized by fever, cough, and shortness of breath, and the really predominant feature is that of hypoxia. So almost all patients with PJP will have hypoxia. It might not be at rest. You may need to walk them around a bit, but usually you will precipitate some hypoxia. The onset of the presentation probably depends a little bit on what their underlying risk factor is. And this is probably more historical, but classically it was thought that HIV patients have a much more subacute onset. So they might be unwell for several weeks before presenting, whereas patients with cancer typically present really unwell really quickly. But I think we are seeing a bit of a mix of that now, so you can see both groups and both presentations in both groups. So the diagnosis is made based on the imaging findings, so diffuse bilateral interstitial infiltrates, and lower respiratory tract sample taken. So again, that's sputum, induced sputum, or bronchoscopy, so bronchial washings. And the way to detect it now is by PCR. That's the test of choice these days, but it used to be doing this direct fluorescent antibody staining. And this is what it would look like if you did that direct fluorescent antibody staining. These kind of like helmet-looking organisms, but it can't be grown. So yeah, that's why we have to rely on PCR. And the limitation of PCR is that it's really, really sensitive. And so if you did it on someone who had a low clinical suspicion of PJP, like didn't have a risk factor, didn't really have the right clinical presentation, you could still find a positive result, but it wouldn't mean that the PJP was causing the problem. So treatment is with high-dose cotrimoxazole. So this is not even an antifungal, it's an antibiotic, but it treats PJP. You use quite high doses, quite a lot higher than you would for bacterial infections. If they've got severe hypoxia, so less than sort of 92% on room air, then there is some evidence for giving adjunctive steroids, and that's to help with the inflammatory component of the pneumonitis, and then support their respiratory state, so oxygen, non-invasive ventilation, invasive ventilation if they need it. And then to try and actually sort of prevent it happening in the first place, we do give prophylaxis to high-risk groups with low-dose once-a-day cotrimoxazole. There are certain risk groups who are at high risk, who you would routinely put them on cotrimoxazole prophylaxis. So just a last slide on antifungals. So I haven't gone into a lot of detail on the exact mechanisms of action of antifungals or the different groups of antifungals. I think I suppose the key thing is just to think of, generally they target the cell wall or the cell membrane, and the three main families are azoles, which is fluconazole would be the most common one you would hear about. Voriconazole, I mentioned, to treat the mold active one, and so is posaconazole. That's one main group, the azoles. And then the second main group is the kinocandins. And again, those are to treat yeasts generally. Azoles treat yeasts and some of them treat mold. And then you've got your polyenes, and of that, in that group sits amphotericin B, and that treats molds. And then there are sort of two other smaller groups, allylamines and pyrimidines, but probably don't need to worry so much about them. So it's more just a recognition of the different groups and just trying to recognise some of the names, really. All right, now I tried to do this as the last slide to get you guys to sort of fill in the table, but it turned out terribly. So what I was going to do is I had these pathogens down the side, the 6 sort of pathogens we talked about, and then the types of infection that they cause. So dermatophytes typically cause tinea or nail infection. Candida species can cause either mucocutaneous candidiasis or invasive candidiasis. Cryptococcus typically is going to cause meningoencephalitis. Aspergillus typically going to cause a pulmonary sort of infection. And pneumocystis is typically going to cause pneumonia. And then the next column was patients who are at risk. So I'll just ask you guys if you can sort of try and fill this in based on what we've just talked about. So dermatophytes, what types of patients get that?
Lots of people, but also people that don't have good immune system.
Yeah, so you're absolutely right. Anyone can get a dermatophyte infection. So the answer is anyone. Candida, sort of mucocutaneous candida, what type of people might be more likely to get that? What sort of risk factors?
Dentures.
Yep, dentures, antibiotics, that type of thing. Cool. What about invasive candidiasis?
Neutropenia, steroids, TPN.
Yep, good. So the sick patient in ICU, gut's broken down, they're on TPN, they've been on broad spectrum antibiotics, they might have some immunocompromise. Yep, good. Cryptococcus causing meningoencephalitis, what's the classic group for that?
Heavy.
HIV, yep, perfect. So HIV would be the main one. Can also see it in cancer patients. Aspergillus.
Immunocompromised with neutropenias.
Perfect, good. So yeah, neutropenia is the main thing. Other immunocompromising conditions like transplant and stuff. Great, and then pneumocystis.
HIV again.
Perfect. Cool. So that was that one. And the last column was treatment. which I'll just pull up here. But so dermatophytes, typically terbinafine, drug of choice, can use azoles. Candida species, usually you want to use fluconazole. Other topical azoles are fine as well, or you can use topical nystatin. Invasive Candida, generally an azole, fluconazole is good, but if they're really sick and upfront, you probably want to treat them with an echinocandin, so caspofungin. Cryptococcus, upfront we give them liposomal amphotericin B. Aspergillus, treatment of choice is voriconazole, and then pneumocystis is cotrimoxazole, so just a star next to that to remind you that it's not an antifungal therapy, it's an antibacterial therapy. Cool, so this is the actual table. I just had a major fail with the other one. So that was all we were going to talk about with fungi. Has anyone got any questions, bits they want to clear up?
With Cryptococcus being encapsulated, was it?
Yeah.
Does it have any relevance with patients who don't have a spleen?
It's not the same type of mechanism that's required to eradicate it. So encapsulated bacterial organisms are managed slightly differently to encapsulated fungal organisms, but often, sometimes what you'll see is people who have a spleen, who don't have a spleen, who also are on steroids and have all these other risk factors, and so they do get cryptococcus, but we don't really know if it's the spleen itself versus just those other risk factors, because you don't classically see it in just people with no spleen.
Okay, thank you.
Cool. All right, so again, happy to take questions via email or whatever, and I'll put these slides up on Moodle. Thanks, guys.
Thank you.
Thank you.
Thanks.
Thank you.